Hello guys, after a long time I'm back with my new video on adenomatoid odontogenic tumor. So, adenomatoid odontogenic tumor is an odontogenic tumor which are found in the oral cavity related to tooth. Odontogenic means it has cause based on tooth. Tooth is the main reason or it's related to tooth. For example, adenomatoid odontogenic tumor, which we are going to discuss right now, calcifying odontogenic tumor, COT, amyloblastoma. These all are benign odontogenic tumors. There are malignant tumors also in this variety. So, for introduction, I would say that it is an uncommon, non invasive, benign epithelial tumor of odontogenic origin, epithelium embedded into the connective tissue stroma. Odontogenic tissues are those which forms the teeth or the structure associated with teeth, that is enamel, dentine, pulp, cementum, gingiva also, characterized by slow progressive growth. As it is a benign tumor, so it is slow growing and have progressive growth. It is generally considered as hematoma. It is also known as two-third tumor because it has a strong relation with 2 by 3 number. That is, two-third of the cases are seen in young women. Two-third of the cases are seen in maxilla. It is strongly associated with maxillary cases. Most of the adenomatoid odontogenic tumor are found in maxilla. Two-thirds of the cases are seen in unerupted canine. So it can cause the impaction of canine also. Clinical features. Basically, what we see in the oral cavity while examining, what we see while intraoral examination. It is predominantly found in young individuals. It doesn't mean that it is not found in older individuals, but it is predominantly found in younger individuals. Female predilection is usually seen, as I have told you, that it is two-third tumor in which two-thirds of the cases are seen in female individuals. So female predilection is there. Maxilla is more affected. 65% of the cases are in maxilla, and mandible has 35% of the cases, roughly estimated data. So again, two-thirds of the cases are found in maxilla. While amyloblastoma is usually seen in posterior teeth, the adenomatoid odontogenic tumor shows highest occurrence in anterior teeth, predominantly cuspid region, that is canine. Majority of the lesions are asymptomatic with size ranging between 1.5 to 3 centimeters. So the majority of lesions are small and asymptomatic, but there are findings of larger lesions of more than 7 centimeter that shows obvious swelling, facial asymmetry as we can see in this picture. Along with that, distortion of the teeth, face and other facial structure can also be seen. Extraosseous gingival lesions can also be found in the case of adenomatoid odontogenic tumor. These are peripheral lesions present as painless gingival mass of 1 to 1.5 centimeter. This is prevalent in maxilla, and female to male ratio is 14:1. Basically, the gingiva is seen as swollen hard mass, and it is in an odontogenic tumor which is seen as a soft tissue tumor. In this picture, we can appreciate the gingival peripheral growth of adenomatoid odontogenic tumor. The macroscopic features include: it appears as soft, rough spherical mass with distinct fibrous capsule. Basically, while you palpate it, it is soft, around roughly spherical in shape, and has a distinct fibrous capsule. The capsule is to limit the tumor within the range, like uh, in cyst formation, there is epithelialization. So there is a distinct fibrous capsule formation around the tumor to limit the growth of the tumor. Along with that, to preserve this other structure, surrounding structure of the teeth. Also, it is the sign that it is a slow growing tumor, because our body defense tries to fight with the tumor cells and tries to limit the tumor cells. So there is fibrosis in slow growing lesions. There is generally seen as fibrosis is seen. But for example, if there was a malignancy growing in there, then this fibrous capsule would not be present, as the tumor cells would be growing very aggressively, fastly, and there would not be a period left for fibrous tissue formation. Under the gross section, the tumor exhibit white to tan, solid to crumbly tissue. One or more cystic spaces can be there of varying sizes, with yellowish brown, fluid or semi-solid material. Fine, hard, gritty, granular material, which can be signs of calcification, and one to several large calcified masses. The calcification can be as small as granular gritty material, and it can be large calcified masses also. Intact specimen demonstrate the crown of an embedded tooth in the solid tumor mass or projecting into the cystic cavity, which is the sign of impaction, mostly seen, as I've told, in the cuspid region, but can also be found in posteriors, maxillary posteriors, also in the mandibular cases, as seen in this picture. Here we can appreciate a tooth coming out of the cystic cavity. So, and in this picture we can see adenomatoid odontogenic tumor is seen, along with an unerupted canine. In the radiographic features, a well demarcated, almost always unilocular, but it can be multilocular also, radiolucency can be seen with smooth corticated border. Sometimes it can be sclerotic because it is slow growing tumor, so we can see sclerotic borders. Most lesions are pericoronal or juxtacoronal with diameter of 1 to 3 centimeter. As I've told, most of the lesions are smaller in size, while some can be as big as 7 centimeter, or peripheral lesions which cannot be appreciated well in the radiographic film. And but most of the lesions are pericoronal, that is surrounded or near the coronal portion of the tooth. The lesion may extend apically beyond the CAJ on at least one side of the root. So the lesion, if it is enlarged enough to surround the tooth and root structure, it can extend apically beyond the CAJ and cover at least one side of the root, or it can also cover both sides of the root. Multilocular cases have been reported, and a scalloped border is observed occasionally. 65% of the cases demonstrate faintly detectable radiopaque foci within the radiolucent lesion. Divergence of roots and displacement of teeth occurs more frequently than root resorption. As I've told that it is often associated with impacted tooth, so there can be divergence of root in case of unerupted canine if it is in primary teeth are not exfoliated, and if the lesion is associated with permanent teeth, then divergence of root can be seen, and displacement of teeth can be occurred due to impaction or mass. If of course, if a mass is growing and it is obstructing the way of the erupting tooth, then displacement of teeth can be occurred. Other radiographic features include orbital and sinus encroachment. Gingival lesions may cause slight erosion of the underlying alveolar bone cortex, but it cannot be clearly seen. as we know that gingiva is an soft tissue structure, so we can't appreciate the radiographic features of the gingiva. If there is a lesion growing on gingiva, we can appreciate the lesion with the help of clinical findings or other tests like MRI imaging techniques. If we want to conduct imaging technique, then MRI can be done, ultrasound can be done, that are soft tissue imaging techniques. A 3D CT image showing anterior wall involving the right maxilla by adenomatoid odontogenic tumor. Here it is, the bone is thoroughly destroyed, and we can appreciate a large mass along with the impacted teeth here and here. So again we can see here the odontogenic tumors, which are variety of tumors found in our oral cavity. In adenomatoid odontogenic tumor, there can be extrafollicular type, which is this and this, C and D. In peripheral type, it can be seen on gingiva, of course between the tooth. Follicular type associated with the tooth. For histogenesis, specific stimulus triggering proliferation of the progenitor cells of AOT is unknown. We don't know how the stimulus affect the proliferation of progenitor cells. The lesion exclusively occur within the tooth-bearing areas of the jaws, most often associated closely with unerupted or impacted tooth. Cytologically, it resembles to dental lamina, and components of enamel organ. Odontogenic origin of this tumor is considered. Histological features include: the tumor consists of spindle, cuboidal and columnar cells. The multinodular proliferation of cells form nest rosette-like structure. Rosette-like structure means flower-like structure that is found in case of rose, or you can see in other flowers also, with eosinophilic material and calcification. Tumor is surrounded by fibrous capsule, as I have told, of variable thickness based on body's immune response. It is characterized by duct-like structure with varying lumen sizes, lined by cuboidal to columnar cell with nuclei polarized away from the lumen. The eosinophilic rim, that is hyaline ring, often lines the duct-like lumina. Stellate reticulum-like spindle cells dominate the tissue between nodules, along with occasional round or polygonal epithelial cells. Basaloid epithelial cells form plexiform, trabecular, cribriform or lattice-like pattern, often in the subcapsular area. Many tumors have cystic areas, as we can see in this picture. So many tumors have cystic areas, possibly from mucoid stroma, pooling or pre-existing cysts. Eosinophilic material at connective tissue interface is immunoreactive for laminin. Many lesions contain irregular to round calcified bodies, sometimes with concentric layers. These are called Lees-Gang rings. Supporting stroma is loose, hypocellular and fibrovascular, often with a prominent vascular component. So differential diagnosis for adenomatoid odontogenic tumor is ameloblastoma, as it is a odontogenic tumor. Dentigerous cyst, often seen as unilocular radiolucency, or calcifying epithelial odontogenic tumor if AOT is calcified or nodular structure is seen. The treatment for AOT is conservative surgical excision, we completely excise the lesion along with the associated tooth. The lesion have low recurrence rate uh, in comparison to OKC, as we have told that OKC has high recurrence rate because of satellite or daughter cysts,